I invite Dr. Apoorva for her talk on advancing imaging, a contemporary guide for DME management.
Thank
Over to
you,
Apoorva.
and sorry for my late entry. I was in another session. Thank you, Dr. Manjunath, for this opportunity. So the first is the oldest, that is Octa. It's a non-invasive modality, detects decorrelation of the OCT signal. We all know about the different vascular plexuses in Octa. So what Octa does is not only can it qualitatively tell us about the changes in DME, it can tell us subclinical vascular changes which you may not see clinically or on OCT. It can detect microaneurysms, phase alterations, remodeling, capillary non-perfusion in eyes with clinically detectable retinopathy and sometimes no retinopathy. So this is a phase enlargement, intercapillary spaces between the that's the capillaries is increased, and here you can see a microaneurysm. It can also map the perfusion, tell us about various vessel densities in different layers, and it has a negative correlation with increasing severity of the DR. So this is an example of how it quantifies the vessel density in each plexus, and it tells us about the intercapillary area. So you can see even in foveal neovascularization, it's so beautifully seen. The phase is beautifully seen. You can make out the flow signal through the vitreoretinal interface. Here you can see that there is advanced neovascularization of the disc and the temporal macula. But fluid interferes with the segmentation. It obscures the anatomical landmarks. Here you can see that when we go through the DME, the cysts, then it becomes all flow voids. And it's important to know that microaneurysms are higher in number in the deep capillary plexus compared to the superficial capillary plexus. Coming to ultra-wide field angiography, it's used in the diagnosis, staging, and management of DR. It detects peripheral NVEs where the posterior pole and the mid-peripheral retina may be normal sometimes. It can help us look at the peripheral vessel leakage, that is late leakage from retinal vessels, and it is seen as hyperfluorescence beyond the vessel walls. This is an example of a 7-field montage, but you can see how much of the retina you can see with a 200-degree field of view. You can calculate the percentage of the ischemia because it's almost like a panretinal view. It can tell you the ischemic index, which is studied to be an independent risk factor for DME. This is how we calculate the ischemic index based on the non-perfusion areas in the macular mid-periphery and the far periphery. Adaptive optics has been around for more than 10 years. Its clinical application has not been very great, mainly because of costs, but it can visualize microcirculation and cone cells at the photoreceptor level. It can tell us about the cell spacing, the cell density, and the cone mosaic structure. So this is an image of a retinal artery. You can see the arterial walls with such clarity. You can see the sheen of the arterial walls. This is an AO fundus photograph. It can be combined with a deformable mirror like a scanning laser ophthalmoscope, an ultra-wide field imaging. So there are many integrations of adaptive optics that has been studied. So whenever you can even superimpose microperimetry on top of the cone mosaic. So there are different things like heterogeneity index. You can see that there are fine structures. This is a hard exudate with hyper and hypofluorescence. You can see hard exudates, these large clumps, and you can see cystic spaces of DME. Increasing irregularity of the cone spacing on AO has correlation with increasing severity of diabetic retinopathy. Of course, it is very logical that there will be decreased cone density in diabetics, and there will be vessel wall changes with decreased vessel diameter, vessel wall thickness, wall to lumen ratio. Coming to the last thing, artificial intelligence in DME, there's a huge role of AI that is coming up with identification of DME and understanding even treatment responses of DME when we use various anti-VEGF agents. So let's look at this graph. Basically, for identification, traditional machine learning based is enough. However, deep learning has been used for both classification, detection, and quantification through segmentation. And understanding treatment responses is mostly deep learn based as well. So what they're saying is, if you teach the machine to detect DME and give it a sample of this particular DME response to this particular agent, it can tell you from a large database whether or not a patient will respond to a particular anti-VEGF. So this is a binary classification framework that separates DME from normals. So this is a little complex, but you can see that it can segment, it can auto encode. This requires a lot of annotation by manual readers also, but you can see these cystic spaces and fluid which can be segmented very well and very comparable to humans. So this is ground truth, where the grader evaluates or marks or annotates the fluid and the cystic spaces, and the segmentation by the machine is very accurate compared to manual graders. So we are also looking into whether AI can detect changes not visible to manual graders, and that is something like retinal layer segmentation and disruption, area exact quantization in terms of nanoliters, which obviously we cannot see, number of hyperreflective dots, optical density ratio, whether there is a difference in the optical density in intraretinal and subretinal fluid, and the classification of anti-VEGF response also, like I said before. And this has improved the efficiency of DME management. Lot of papers in the last 3 years. It has enabled precise customization of therapeutic schedule, when the patient should get the next injection, for example, and the probability of whether they'll respond to a particular anti-VEGF treatment. Thank you.
Thank you very much, Dr. Apoorva, for that wonderful talk. So how extensively do you use Okta in your management of DMEs? Is it as much as...
Yeah, that's a very good question. In DME, not much, but one application of Okta I found in diabetics was when there's unexplained vision loss and it is not correlating to the OCT. And you have some parafoveal edema, only evidence is some disruption of the outer layers, but Okta shows very impressive changes when there is phase changes, capillary dropout, and you can attribute very easily, show the patient that this is what is happening in your eye, there's no circulation. So that is a very important application of Okta in my practice.
do you always do an Okta for all your patients before starting anti-VEGF therapy, or not at all?
No. Only when I suspect macular ischemia, because my fluid will interfere with my Okta signals. So fluid is a damper, it will just show flow voids and it should not be interpreted as capillary loss.
Any questions from the audience?
Yeah. So now, is there any role of FFA in diabetic macular edema?
Definitely. If there is a recalcitrant DME and there are parafoveal cystic changes, and
No, means compared to Okta, if we have option of Okta.
so you have Okta and FFA, then both of them have very specific indications.
Okay.
OCT is still the modality for the win in DME, but Okta only if suspecting macular ischemia. FFA also helps, but it is invasive. If you want to plan a focal laser, then FFA is the way to go.
Thank you very